Thank you, and thank you all for coming out tonight. My name is Fidelma Fitzpatrick, and I've two parts to my job. I'm a doctor in Beaumont Hospital, and I see patients with infection. And every week that I'm on call, I go around the intensive care unit with Ger, and we talk a lot about sepsis. The other part of my job is I teach medical students. These are the doctors of the future. And every year when I talk about sepsis to these very junior medical students, I show them your video, Kieran. So none of the RCSI graduates will ever forget Rory. So we've talked a lot about sepsis, but let's stand back from this. People with infection present in very different ways. So it's the time of year that we've got coughs and colds. So most of us have a viral infection, and we never go near doctors. Some of us might have infections that take us to our beds, and we feel very miserable, and we have flus and take paracetamol to help those shivers and shakes. Sometimes from our beds, we might have to go to doctors, but we usually come back to our bed. So most people that have an infection, be it bacteria, a virus, or a fungus, don't have sepsis. So when do you have sepsis? Because when you do have sepsis, it's really important, as we've heard, you don't stay in your bed and you get medical help. So let's go back to the infection. So how do you know you've an infection? Well, most of us know we've an infection. And a lot of the time it's because of these non-specific signs and symptoms. So we feel miserable, we've shivers and shakes, we've got kind of muscle pains and joint pains. Sometimes we've signs and symptoms related to the sign of infection. So if we've an upper respiratory tract infection, we probably have a blocked nose. If we've a kidney infection, we're running to the toilet a lot. If we've a chest infection, we're probably coughing up green spit. So between the non-specific signs and symptoms and the signs and symptoms related to the site of infection, most of us know when we have an infection. The other thing that's happening in the background is what we've heard earlier on, is our body is trying to fight the invader. And our body mounts a response known as the systemic inflammatory response syndrome. It does it to lots of things, not just infections. And generally what happens is either our temperature goes up or down, our blood pressure might go down, our heart rate goes up, or our respiratory rate goes up. And these are signs that in hospitals or in your GP we can measure. We can measure temperature, blood pressure, and pulse rate. So what's sepsis then? So I've said to you that most infections aren't sepsis. Well, what sepsis is an infection that affects the functions of the body's organs. And it is a life-threatening condition. So this is the way I visualize it. You have an infection and you get a host response. That's good. That's what we're meant to do. But in sepsis, this host response isn't regulated. And as a result, we get damage to the bodies of the organs of our body even. And that's when we have potential death. Now, I'm a very simple person, so I have to think of it like this. Our body is a very finely tuned orchestra. When we have an infection, our body responds in time and in tune. It doesn't happen like that with sepsis. It's dysregulated and the organs don't work properly. So how would you know you've organ dysfunction? Well, later on we'll distribute some booklets that hopefully will help. But I've got my nephew Gavin to help me out on this one. So if the organ was the brain and it wasn't functioning right, and you were caring for somebody, you might notice that they weren't really acting themselves, or they might be a bit agitated or confused, or they might be sleepy and difficult to wake up. If the organ was their heart and circulation, they could be cold or clammy and pale. They might say they're a bit dizzy, or you might feel their pulse and it might be going really fast. Sometimes sepsis, depending on the infection, can affect the skin. And that's when we do the glass test. And it's a rash that you have on your skin that doesn't go away when you press with glass. If the organ that's not working is the kidneys, or are the kidneys even, you might say, have you passed urine? And you may notice that somebody hasn't passed urine in the last 10 or so hours. That's not good. And lastly, if the organ is the lungs, you might notice somebody's breathing very fast, they're laboured, or their lips were blue. So as you can see, the signs and symptoms of sepsis are very varied. They're very varied because the bugs that cause sepsis are very varied. There can be lots of different organs involved, so you could have a chest infection with sepsis, a kidney infection with sepsis, a tummy infection with sepsis. And also, we're all different. We all respond differently to infection. But it's very important that we all ask that question, could it be sepsis? And aware of some of these clues. So why would you need a national programme? And that's what I'm here to talk about. Because if we know what the signs and symptoms are of infection, and we know what the signs of organ dysfunction are, why would you need a national programme? Well, first of all, sepsis is a time-dependent medical emergency. For every 1 hour that antibiotics are delayed, mortality goes up by 7.6. And that's exponential. 2 hours, it's 7.6 plus 7.6, and you can figure the rest of it out yourself. And the reason why we need a national overall approach in Ireland is to define what sepsis is. Because we don't have time for it to be woolly. We don't have time for somebody to go, what was that you said before? We need to know this is sepsis. Because once you can name sepsis and recognise it, then you can do something about it. Then you can have a framework for clinical intervention, which basically means this. Once you recognise sepsis, patients have to be resuscitated if I'm their doctor, and also I need to know when to seek help, when to refer. Do I need to call GER and get the patients to critical care? Or do I need to ask somebody else to help me deal with the problem? And recognition and naming sepsis is really important. The Australian database, which has gone on for many years, has seen that for 90% of people that had a poor outcome for sepsis, it was delays in recognition that was the problem. Because once you recognise, then you know what to do. And what is resuscitation? And we've heard about this. It's the sepsis superheroes, as we call them. But it's antibiotics, fluids, that's the Hartmans, oxygen if needed, checking urine output, and taking some blood tests. So in sepsis, it's all about the R's. It's recognition, resuscitation, and referral. So who are we in the national programme? Because I've already told you I work in Beaumont in the College of Surgeons. So clearly I have a sideline with the national programme. Well, I chair, that's me, Smiley, and all the rest of it. So I chair the sepsis steering group. But actually I'm kind of like the coordinator per se. The person that's actually leading the programme is Dr. Vida Hamilton, who's an intensivist that works in Waterford. And she's supported by Christine, who's our programme manager, under the governance of Anya Carroll, and that's in the Clinical Strategy and Programmes Division of the HSE. But all the other people here are our regional sepsis nurses. So in Ireland, hospitals are grouped with universities. So for example, Beaumont is in the RCSI hospitals group, and Mary Bedding is our regional sepsis nurse. So it's a small but tight team, and for gender balance we've included Ronan from the West, clearly. So one of the first things we did is launch guidelines. Well, we didn't launch them, we wrote the guidelines. But in conjunction with colleagues from the Department of Health, we produced national sepsis guidelines for Ireland. And we produced them in 2014. And that was very important that these guidelines were endorsed from the top, from the Department of Health. And it says a lot that the then Minister for Health, the head of the HSE and the Chief Medical Officer launched those guidelines. That's how seriously sepsis is viewed, and rightly so. And we've had 4 national sepsis summits so far, and Kieran has been a fantastic supporter to us, both personally and also coming to share his story. Because remember, every time Kieran talks, he's breaking his heart all over again. So we're very grateful, Kieran, you come and tell your story. And what's been also wonderful with these sepsis summits is over time we're less and less reliant on all the international experts. And that's brilliant, because it means we've more and more talks from everybody around the country telling us what they're doing and how they're tackling sepsis. One of the things we've produced are tools, or rather forms and flashcards. But just think about this. I don't know if you've ever been in a hospital, but I work in a hospital all the time. Nobody stays still. This is very unusual for me to actually stay this still. Normally I'd be up and down and around. Hospitals are very fast, busy places. I've already told you that sepsis is a time-dependent medical emergency. We have to produce tools to make it easy for healthcare staff to recognise sepsis fast and not have to look up their phones and check what sepsis is. So some of these tools are literally tick box forms that help you check off and tick off what is sepsis and what it isn't. And in the hospitals we've these forms for the adults, for paediatrics and for maternity. We're piloting forms in long-term care, and we're working with GPs for the primary care. And we've also worked a lot with the ambulance service, because it's very important, no matter where somebody contacts healthcare, that everybody knows what we actually mean by sepsis. And this is an example of the tick box form. Like, it's all very well to say doctors should know all of this, but if you're in a busy emergency department with 50 million patients to see, you cannot rely on thinking about things. It's much easier to look at this and go, does the patient have any of this? If they have, tick. This is sepsis, now I know what I'm dealing with. It's just a tool, but it helps. Also staff education, because when I grew up in the 1880s in medical school, we were taught about infections. The language of sepsis wasn't used, because people have infections, but sepsis is an overall term for an infection with organ dysfunction. So it's really important all medical staff, no matter where they work, know what sepsis is. And the regional nurses and sepsis teams on the ground have been leading this. But we also have a national e-learning programme, which you get a nice cert when you finish. Now, I don't know about you, but I felt under extreme pressure when I did this e-learning programme, because I realised at the end people would know my score, and if I didn't pass, I'd have to do it again. So I felt very embarrassed if I failed, but I didn't. I passed first time. We've also produced public information, because it is scary. Like, it really is. If you're sitting here, you must have the living daylight scared out of you after the last few speakers. And in a way, rightly so. But you also want to have that fear being proportionate. You need to know what an infection is and when it could be sepsis. And the booklets you'll get out, which I hope are helpful, Vida and the sepsis team have produced. And they're meant to be helpful to let you know what sepsis is and isn't. So the latter part of my talk will be talking about facts, because it's all very well to have international facts, but it's much more important to have facts from Ireland. And we've produced 2 national sepsis reports. And the source of this data is the hospital data. It's the hospital inpatient inquiry data that every hospital uses. So I'm going to present some facts. They're publicly available and they're on the HSE Sepsis website. So the first thing, as you've heard before, is in 2016, 14,804 people had sepsis in Irish hospitals. That's a 67% increase from the previous year. That's good, because that means we're getting better at recognising sepsis. And once you recognise sepsis, you know what to do. So when sometimes people are talking about increasing incidence, the increasing incidence can also be increasing recognition, which is good. Now, the people that had sepsis spent 20 days of their life in hospital on average. That's nearly 3 weeks they'll never get back. Never mind the long-term consequences when they get home. We're in a health service where people are talking about elective waiting lists and trolleys on the emergency department. Those 20 days rounded up to 300,000 bed days. Even if we were able to prevent a small proportion of patients with sepsis, could you imagine how many people we'd get off trolleys and waiting lists? So there's a bigger argument to be had in terms of trying to focus on sepsis that will impact on other parts of our healthcare system. Now, no age is immune from sepsis, but sepsis does tend to increase with age. And the reasons for that kind of make sense, because as you get older, your body's a bit older, so your immune system is a bit older. We also, as we get older, accumulate diseases like diabetes and heart disease and kidney disease and lung disease. So we're probably a bit more vulnerable not only to infection, but from the bad infection with organ dysfunction. Mortality also increases with age, specifically from 75 years upwards. There's also a small peak in mortality in the under ones, and that also makes sense because they have a very immature immune system. So let's look at the numbers a different way. And this is 2016. There was nearly 500,000, 439,000 inpatients in Irish hospitals. Of those, 11,000 died. The crude mortality rate was 2.5%. That's sepsis. So those 14,000 patients represent 3% of hospital inpatients. Of those, nearly 3,000 died. That represents 1 in 4 hospital deaths. And look at that mortality rate. And look how it compares to other infections and all the other diagnoses. So sepsis is associated with huge mortality. Other facts and figures, some of which probably isn't surprising. I've already said that sepsis and mortality increases with age, but mortality also increases with the number of comorbidities. So comorbidities mean other diseases like heart disease and lung disease. So if you just had lung disease, that's 1 comorbidity. If you had lung and heart disease, that's 2. And if you had something else, that's 3. So the more other things that are wrong with you, the poorer you're going to do if you have sepsis. In mortality rates, we've data from 2011 onwards. And actually, there has been a decrease in mortality in Ireland from 26 to 18.3. And what's interesting, but we're not cracking open the champagne yet because there's a lot of work still to do, is the Irish guidelines and the programme really got going in 2014. And certainly 2016, when there was increased recognition and we had more cases, our mortality went down. So that's hopeful, but that's still far too many people. Other interesting things we've noticed is mortality from sepsis is seasonal. It peaks during winter. Now it probably does so because in the middle of flu season we get flu and we get other infections on top of flu, bad pneumonias. And that's why other campaigns are so important to try and prevent sepsis. Could you imagine if everybody that should got their flu vaccine and their pneumococcal pneumonia vaccine? I wonder how many of those deaths would have been prevented. Now, men are for Mars and all the rest of it, but sepsis from the Irish data is more common in males. And this kind of thing actually has been described in the literature, gender differences between boys and girls for infection. It's all to do with the differences in our biology and our hormones. But unlike a lot of the international data, we haven't seen any difference in mortality rates between boys and girls. What we have seen is how important it is to recognise patients with organ dysfunction, i.e. patients with sepsis, because mortality rates double. So how does that compare? So if I've probably bamboozled you with figures, let's look at the 19% mortality rate from sepsis in 2016 in Ireland. Germany 2012-2013 reported 24% mortality. Australia, New Zealand, 18%. And then a study of 7 high-income countries reported a mortality rate of 26%, and that was infection with organ dysfunction. So certainly we're not the worst, but it's not good. This isn't time for complacency. We want to be the best in terms of low mortality rates. The other thing we've tried to do with the programme is not just collect data, because collecting data and publishing fancy reports is just a waste of time. Our job is to try and save lives from sepsis. So we've noticed from the 2016 data that there was 3 categories of patients specifically that had a mortality rate of 20%. So it was much higher than all the other mortality rates. And they were immunosuppressed patients, generally cancer patients, when their white cells went down, either from the cancer or from chemotherapy. There are people with new onset organ failure. And then there's people with comorbidities and this inflammatory response syndrome. And we've changed the age to 75 because, as I showed you, the dramatic increase in mortality from the age of 75. So this is the form we're using in Irish hospitals at the moment. But it may change if the data changes, because it's important we always look at data and ask questions. So one of my other day jobs is looking at antibiotics and being concerned that in the last 20 years, we've had no new class of antibiotics being produced. And we've already heard how important antibiotics are for sepsis. So if you're following this, you might think, if people are going to start using all these antibiotics for sepsis, what's going to happen with antibiotic resistance? Well, what we say in the sepsis programme is you use antibiotics appropriately. So you don't use domestos when something like fairy liquid will do, essentially. So it's the same with antibiotics. You use appropriate antibiotics and prescribe them accordingly. But we've also monitored some of the infection rates for antibiotic resistance. So the programme is tied in with the National Antibiotic Resistance Programme and also with the Health Protection Surveillance Centre, which is the national surveillance centre that collects data on infection. So we're keeping an eye on antibiotic use data and also the superbug data, because it's very important we ask questions and make sure that everything is tied in together and not lots of parallel processes. And to my knowledge, we're one of the few sepsis programmes in the world that's tied in with so many other aspects like that. So there's a lot of information everywhere on the internet. One source of information Vida and her colleagues have put up on the HSC website. And essentially, everything I've shown you tonight is up there, apart from my nieces and nephews' pictures. They're just on Twitter. And tells you a little bit about who's on the programme, about some of the national sepsis summits, some of the presentations are up there, and all the guidelines. And the patient information leaflets are going to be up there soon. So before I finished, the National Sepsis team, I just chaired the committee. Really, these people do all the work. Vida, Christina, and all the sepsis nurses. There's a large group of people on the sepsis steering group, including patient representatives. And that's really very important, because sometimes we get caught and can't see the wood from the trees. So it's very important for us to remember why we're actually there, and it's not just to go to a committee meeting. We've had huge support from colleagues in the Department of Health to get the programme off the ground. And the cartoonists are Owen Kelleher, who was an anaesthetist in Beaumont, or was an intern a few years ago. So he drew the sepsis superheroes. And lastly, the Nino pictures and the other pictures are courtesy of Daniel, who's 10, Elena, who's 9, and Gavin, who's 7. And they're my nieces and nephews. And they know far more about sepsis and superbugs than your average 10, 9, and 7-year-old. But start them young. Thank you very much.